That's all. Esophagus. Muscular structure, by the way, upper portion has the voluntary muscles, yeah, it is striated muscles. Lower portion is smooth muscles. Esophagus has not two, but esophagus has three portions. That is cervical, that is thoracic, and that is abdominal portion. Esophagus has three natural narrow places, two located in the neck and thorax region, one located in abdominal region. First place, as you remember, it is natural border between your trachea and between your esophagus and between your pharynx. Second one, it is cross point with aorta large. And last part, it is place of connection with cardia of the stomach. Esophagus, as I say, you shift it a little bit into the left side due to the pressure with the heart and with the aorta. As your left pleural cavity, as your left lung, they also push, they also shift into the left due to the pressure of the heart and the biggest vessels. Same for esophagus. Symptom of esophagus. In front of it you will have trachea, in front of it you will have left lobe of your thyroid gland. From sides and in front you will have the same carotid neurovascular bundle. From behind you will have the vertebra. From sides you will have deep muscles. It is the locus muscles of the neck. Arterial supplement, venous drainage and innervation, absolutely same. What do I say before? Inferior thyroid arteries, inferior thyroid veins, esophageal drain inside of the sympathetical innervation from triganglius, parasympathetical from nervus laryngeus rectus. That's all. Lymphatic drainage again to the trunk of the internal jugular vein. Questions? If no questions, let's close this and let's open the next our topic. It is the sternocleidomastoid region. Sternocleidomastoid region. Minute attention. As you understand, then we say sternocleidomastoid region. We imagine sternocleidomastoid muscle. So borders of muscle and borders of region is absolutely coincide to each other. But 1 minute attention. Border of space and borders of region is not same. Now look to me. This is my SCM region. In the same time, this is my SCM muscle. From upwards it is the crista mastoidea. From down it is sternoclavicular joint. From in front, anterior margin, from behind, posterior margin. But I'm very sorry, capsule is much more bigger. I put one finger in front and one finger behind of my SCM, and still I have the capsule of it. Hold your hand like this. That is muscle, that is capsule. You can see that, thank you very much, this capsule is much more bigger than the muscle, which is the key. That's why, if you will make incision along the posterior or along the anterior margin of SCM, you will enter into the capsule. Remember about this, I can say that partly this capsule enter into medial triangle, because in front of SCM you have medial triangle. Partly it is enter into the lateral triangle. It's behind of your SCM. Don't sleep.
No, we sleep.
Repeat.
So you said that the sternocleidomastoid, like the capsule.
I interrupt your sleeping process.
No,
I don't say it. I say that. I forget. I say that anteriorly it is entering inside of the medial triangle, posteriorly inside of the lateral triangle. That is what I say, not what do you say. Let's continue. This is, friends, about the region borders. Now let's speak about region layers. Do you remember that I drew my first diagram about neck region? I told you that SCM divided into upper two-thirds and lower one. Why we make this division? Because now you will see that and quality of layers, and what is much more important, the quantity of the layers will be different. But let's start from quality, skin. The more higher you will go, the more thicker and less movable will be skin. Now, make the fold near of your mastoid. and near of your sternoclavicular joint. And say me, where is more easy? Of course, because the more lower you go, the more thinner become the skin, and vice versa. Same with fat. Same with fat. The more higher you go, the more better it is developed. Then you look down, sorry, you see depressions. What is show depression? Depression show absent or bad developed fatty tissue. Because then the fat is great developed, we have protrusion, we don't have depression. That's why remember, please, and skin and fatty tissue from up to down is changed. Skin from up to down stand thinner, fat stand less developed. But inside of fat there are structures which you know very well. It is anterior jugular veins. They pass strongly by anterior margin of SL. They are located primarily between first and second fissure. But many detention, 3-4 centimeters above the jugular notch. They perforated second fissure and they become to the suprasternal space. As you remember, right and left anterior veins join to each other and they form jugular venous arch, which is located parallelly to your notch and 1 finger above it. Remember it, guys, that is not hard. Let's continue. Inside of the fatty tissue also we have the superficial nerves. Now look to me. All branches of cervical plexus come to fatty tissue in same point. This is midpoint of posterior margin of your SL. So they originated inside of the neck from C1, C4. You remember, by the way, whom to ask? Whom? Friend, you, because you are a good student. Tell me please, how plexuses of human body, neurospinal plexuses is originated?
The posterior, the dorsal surface of the vertebral.
Do you understand my question? We have several plexuses. By the way, how many?
5.
Name.
Cervical, brachial, sacral, lumbar. Cervical, brachial, lumbar, sacral, and
There is the 5th one, which you mentioned.
4th one.
This is 4 main plexuses. Yeah, how they form?
C1 to
No, I don't need to listen about exact segments. I speak about common rule of their formation.
The lateral.
No, of course, thank you very much. By interior branches of the spinal nerves. Remember, please, spinal nerves split it into anterior and posterior branch. Posterior doesn't have any attention to the formation of the plexus. All the interior, exception it is thoracic portion. As you remember, thoracic portion doesn't form primary generally. Yeah, the T1 can be involved in upper one, T12 in lower one, but generally thoracic portion doesn't form the plexuses. It gives the intercostal nerves. So remember about it. That's it. We speak now about C1, C4 segments. It is formed the plexus between the deep muscles. Yeah. After it gives the 2 type of branches, as you remember. Primary, it is sensory branches, and there are 1 mixed branch, motor branches into the muscles, and 1 mixed branch, it is nervus cranius, which is descended up to your diaphragm, and primary make the innervate, not only diaphragm, it gives the branches to the pericardium, yeah, pericardiophrenical branches, as you remember, but primary, it is make the motor innervation of your diaphragm, which is main your breathing muscle, main your breathing. By the way, very unique muscle. It has a voluntary compartment and involuntary innervation. Usually when you leave, you don't think about your breathing. It is happen automatically. But if you want, you can regulate. You can breathe more or less. So remember please, it has dualistical, it is unique muscle, which has dualistical regulation and vegetative regulation. And in the same time, it has also the voluntary regulation. Okay, but now let's continue. Which nerves is it? You know, 4 primary nerves. Yeah, it is ascending 2 nerves, occipitalis minor, auricularis magnus, horizontal 1 nerve, transversus cervicalis, and 1 descending supraclavicularis, which is divided into medialis, media, and lateralis. All of them come to the fatty tissue, again I say you, from same point, midpoint of posterior margin. Very important point, by the way. If I will put my finger in this point, and will press into inside. What will be happen? Don't do it. We will press common carotid artery into the tuber caroticum, which is located in transverse process of C6. You understand me or not? Now look, my finger it is tuber caroticum on the transverse process. The pen it is common carotid. Now push it. It will be present, closed, and bleeding is stopped. Temporal method of arresting of the bleedings in case of the leg and in case of the head region. If you will do it from two sides, you will kill the patient. Because the blood supply of the brain will be closed. By the way, half of the minute will be enough for syncope. And after the person will be dead. Losing for the consciousness. Idea is understandable for you guys. Okay, let's continue. That's like, you can see now that in fatty tissue we have several structures. Let's continue. Next layer, number 3, it is superficial fascia. It forms the capsule for platysma. By the way, if my pen will be SCM, my head will be platysma. You see that it covers middle third, not the lower, not the upper. You understand what I tell you? That is important to make surgical access. You must understand what you will cut. So remember, this platysma covered mainly middle third. Little bit more than middle third, but middle portion. Uppermost 5 and lower 5 centimeters doesn't cover. By the way, what is the function of your SL muscle? Yes. Then it is constricted. Which kind of the movements you do? Now put your hand in one ear SL. Now please make the tension of the skin to down. What is happening with your head? Tilting movement. If one-sided SCM, now do it by 2 hands. What will be happening? Oh. Frank, why you so press your, of course, flexion. If both-sided SCM, yeah guys, by the way, by such kind of the tensions, if you forget the muscular function, you can simply modulate it. For example, you forget the biceps function, put and make the tension of the skin. You will see approximately which kind of the movement will be. And like this for any muscle. So of course, if it is very deep muscle, it will be impossible to modulate it. But for muscles which is near the surface, you can simply do it. Samely for the thoracic muscle, simply for that. Let's say if two-sided muscle is flexed, we have a flexion, constrict. If one-sided, we have tilting. So remember, please, once again, SCM covered by platysma only in middle portion. Upper and lower portion doesn't cover. Under the first fascia and platysma, I have second fascia. We know modulated together, very huge capsule, not so big muscle inside of it. Of course, we have loose connective. Of course, we have lymphatics. We have sternocleidomastoid vessels. Yesterday, we say that artery originated from external carotid. Vein is drained into the internal jugular. And there are nervous accessories, which is the 11 cranial nerve, by which opportunities go out from cranial cavity. 11. Of course, thank you very much. You're very clever. With which nerves? Brilliant, beautiful answer. Then it is descending to the primary perforated anterior margin of SM capsule, innervated SM, then perforated posterior wall of the capsule, and tends up to your trapezius muscle. Not main innervation. Let's say this is two muscles which is innervated by your accessorious muscle from in front SM, from behind trapezius. That's all. But let's go deeper. Look. Starting from next layer, we will see different layers in upper 2/3 and in lower 1/3. What is located in upper 2/3 under the second fascia? No third, no fourth. No third, no fourth. Why no third? Because no infrahyoid muscles in upper third. Why no fourth? Because no organs and the carotid neurovascular bundle. You understand me? Once again I tell you, under the second fissure, in the upper two-thirds of SCM muscle, immediately we have last fissure, fifth one. By the way, between second and fifth here, we will have still the same nervus accessorius, which from SCM will pass to the trapezius between these two fasces to make the innervation of it. But what we have in lower one-third, to be very attentive, guys, first and last time I described it up to your midterm examinations. Of course, under the second in lower third, first of all, you will have retro SCM space, which is between second and third. Then I will have third fissure. Then I will have parietal layer of fourth fissure. Because now look to my pen, I put it immediately by projection of the carotid neurovascular bundle. As you remember, upper point, it is midpoint of distance between angle of mandible and apex of mastoid. Lower in right side, sternoclavicular joint. In left side, midpoint of the distance between two bellies of the SCM. By the way, why it's happened? Why lower point of common carotid projection is different in right and left side? What is phenomena you see? Why upper point is same, but lower point of projection of this artery is different in right and left? So, am I check the knowledge of your friend or no? Maybe you? Maybe you? Maybe you? Maybe you? Oh, maybe you?
Is it because the out has the
Why so long?
brachiocephalic?
Why so long? You must to say just 3 words or 4. They have different origins. They have different origins. What it mean?
They have ascending.
Friends, tell me this puzzle. How you pass your anatomy if you don't know the biggest vessels of your body? Then I will see that Nina, I will ask this question to her. How she put the mark for you? You know, I asked not about some second. This is biggest vessels of human body. Biggest. Bigger than these vessels, we have only aorta. So how is it possible to not know? But you know, you must have so fresh knowledge just one semester before you study. How is it possible? Your aorta large gives only 3 branches, only 3. From right to left, brachiocephalic, left common carotid, left cephalic. Nothing more. You see that origin is different. For right one, it is located more medially from brachiocephalic trunk. From left one, it's located more laterally from separate branch of aorta large. That is the cross by inferior points of projection, which is place of origin. Superior point of projection, it is place of finish. By the way, of course, your common carotid artery doesn't reach this point. This point is necessary just to show the direction of it. Because in this point, it will be finished. What is this point? It is upper margin of your thyroid cartilage. That's an upper point which we take for projection. Doesn't show the real location of common carotid. It will be internal carotid, its continuation. But your common carotid, look, I find the upper margin of my thyroid cartilage. I provide it horizontal line, and I see level where it is finished inside of carotid triangle. Above this horizontal layer, I don't have any common carotid. I have external and internal. By the way, common carotid, you can project it on the inside of only carotid triangle, not in whole neck. It's much more simple. Look, 1 minute, look to me, Emily. You find the angle between your omohyoid and between your SCM. And you make the bisector of this angle. Bisector, split the angle into 2 points. Bisector of angle between your omohyoid and between your SCM. When projected this artery strongly, not in whole neck, but immediately in the carotid triangle to make the access to it. Is it understandable for you? Very well. That's why, guys, now I prove you and I show you that in upper 2/3 of SCM and in the lower 1/3 of SCM, layers is absolutely different. And the difference started from the second fish. Before this, we have the quality difference. After this, we have the quantity. If in upper third, after upper 2/3, after second, we have immediately fifth. In the lower 1/3, after second, we have space. Then we have third. Then we have parietal layer of the fourth, which is called spatium vasum nevrorum for carotid neuron, and finally fifth one. The idea is understandable. That's a third and fourth, which is presented in lower third, absolutely absent in other clinics. By the way, fifth fascia here covered not only vertebra, but it's also covered subclavian neurovascular backbone. You know, your neck has not one, but two neurovascular bundles. By the way, one is vertical, second is horizontal. Vertical one, it is of course carotid. Horizontal one, of course, it is subclavian. In reality, it's not horizontal. It is oblique descending, because finally it descended to upper extremity. By the way, point of the border between your subclavian and axillary arteries will be midpoint of your clavicle. Above this midpoint, you have subclavian. Below this midpoint, you have axillary. One minute. Do you understand it? Brilliant, I'm so happy. Let's come to last hour triangle, which we'll study together with you. Of course, it is the lateral triangle of the neck. As usually borders. It's so simple to imagine, look to me. From in front I have posterior margin of SCM. From behind I have anterior margin of trapezius. From down I have clavicle. Okay. Anteriorly posterior margin of SCM. Posteriorly anterior margin of trapezius. From down clavicle. But inside of this big triangle, now imagine inferior belly of omohyoid muscle, which is splitting this big triangle into two parts, upwards omotrapezoid, downwards omopolypoid. So, is it necessary to open the picture, or do you imagine? Huh? To open. So it's so simple. Look, posterior margin of SCM, anterior margin of trapezius, clavicle. Now imagine the line which is obliquely passed between these anterior and posterior margins. It will be inferior belly of omohyoid. Above it will be omotrapezoid triangle. Below it will be omodominant triangle. Is it understandable? Super. Now let's speak about layers. You know, again, some layers will be common, same, and other layers will be different. Let's start from skin. Skin is skin, of course, but skin has different characteristics. Again, I tell you, more higher, the more thicker and less movable. More lower, the more movable and thinner. Remember about it, samely for fat. Don't forget that we have very developed supraclavicular fossa. Fossa show absence of the fat or bad developed fat, generally. But the upper portion has great fatty pad, even you can palpate it, soft structure, inferiorly no. Inferiorly no. Inside of the fatty tissue, by the way, you will have the same branchings of the cervical plexus, which I mentioned before, in SCM region. They will be also inside of the lateral triangle. Platysma muscle, guys, everything is simple here. Look, omotrapezoid covered completely. Omoclavicular doesn't cover by the medial portion. Because as you remember, platysma located in such a way, by big line, they doesn't fuse to each other. That's a medial portion of your omoclavicular triangle will not be covered by this platysma. First fissure, then we have second fissure. Second fissure, guys, in both parts of these triangles and anterior posterior, split it into two layers. Anteriorly for SCM, posteriorly for trapezius muscle. Anteriorly it forms capsule for SCM muscle, posteriorly it forms capsule for the trapezius muscle. I think it is same. But starting again, look at like in SCM region, starting from second fissure, layers will be changed. In upper triangle, again, immediately fifth fissure. In lower triangle, what is lower triangle? Between two omohyoids. You know, between two omohyoids, we have fascia number 3. That's under the second fissure. First of all, we will have supraclavicular closed space, which is formed between second and third fissure. Then we will have third fissure, and then we will have only fifth fissure. That's a lower triangle content third fissure, upper triangle doesn't contain third fissure. Remember it. Now write the name of small diagram. Scalene vertebral triangle. Scalene vertebral triangle. And first of all, before start to draw it for you, let's imagine.